Can you talk specifically about why safe injection sites are viewed as this method to further along someone's journey towards perhaps even getting opiates out of their system altogether? Why safe injection sites, and why is it seeming so politically satiable and accepting?
Yeah. So an argument in support of consumption sites, in my understanding of harm reduction, would ensure that they have outreach to connect to people who are at risk and who are not using them. We
Right,
know that
right,
even among the people who use consumption sites, they don't use them all the time.
right, right.
But there are many people, for a variety of reasons, and this has been well described in the literature, don't feel comfortable coming to consumption sites. So we need to do better outreach to engage people if we're going to use consumption sites as a kind of a key node or gathering place.
Right.
The other thing we don't have that. The other thing we need is an array of throughput options for people, so that we are not using consumption sites to enable ongoing substance use, which has its own related risks, and that we're identifying the psychological syndromes that people are experiencing at the same time, which may overlap again with trauma, but other things too. In our work, about a third of the people in BC who are prescribed methadone for opiate use disorder are also diagnosed with either schizophrenia or bipolar disorder, which
Right.
are non-trivial psychological struggles and symptom clusters that need to be attended to in a specific way, and their support, their clinical support, has implications for the inclusion of other drugs like methamphetamine or
Right.
opioids, for example, as you can imagine. So we need to be doing careful assessments of people because we know that there's a high probability that they have these additional things going on. And then we need to be able to very, very quickly, in order to reduce the risks of poisoning and other risks they're exposed to, move them into options, and they can be given to them as options, voluntary options that are known to have a powerful effect on helping them reduce their own risks. That would include things like dispersed housing, therapeutic communities, which are places where people can stay for usually months to a couple of years. And they're doing two things in our case, that they need to do two things. One is give people day after day of practice going through the day without using drugs addictively. And the second is preparation for employment afterwards, so that they have a confidence in an in-demand skill set that is going to provide them with rewarding community involvement when they transition. So if consumption sites were bracketed in this way to help move people through into a process of social reintegration, they could live up to their potential. But that's not what they're doing. They're very limited in what they're doing. They're quite defensive about what they're doing. And they, rather than serving as a point of throughput, they become magnets for additional forms of harm. And this includes people who are dealing in theft of stolen merchandise. They'll concentrate around consumption sites in order to engage in exchange. They're also attracting people who are trafficking illicit drugs that people are wanting to use. And depending on their adjacency to pharmacies, the consumption sites to pharmacies, they're also attracting people who will criminally purchase dispensed drugs to people, which are ostensibly, supposed to reduce risk by, you get the dispensed drug, then you go to the consumption site, and you're at least taking something of a known dose. But what we hear about and have evidence of is that people are, in some large measure, selling the prescribed drugs, purchasing illicit drugs, and so all of this activity starts to become concentrated around these sites because there's no emphasis on throughput.